Here's something most people don't realize about GLP-1 weight loss drugs. They don't actually create anything new in your body. They copy a hormone you already produce every single time you eat. That single fact changes how you should think about these medications entirely, and it's exactly where we're starting today. Over the past few years, medications like Semaglutide and tirzepatide, sold under various brand names, have gone from specialized diabetes treatments to some of the most talked about weight management drugs in the world. With that popularity has come a flood of information, some accurate, some exaggerated, and some genuinely misleading. So today we're breaking down what these medications actually are, how they work, what the research really shows, who they're typically prescribed for, and what doctors want patients to understand clearly before considering them. Think of this as the conversation before the conversation with your doctor. Let's start with GLP-1 itself. Glucagon-like peptide 1 is a hormone your intestines release naturally after you eat. It tells your pancreas to release insulin, slows down how quickly your stomach empties, and signals to your brain that you're full. GLP-1 receptor agonist medications mimic this natural hormone, but in a far more sustained and pronounced way than your body produces on its own. That's the entire concept in one sentence. It's not a new mechanism. It's an amplified version of something your body already does. These drugs were originally developed for type 2 diabetes to improve insulin response and blood sugar control. During those early trials, researchers noticed something they weren't specifically looking for. Patients were also losing significant amounts of body weight. That observation is what led to dedicated weight management research and eventually to specific versions of these drugs being approved for that purpose in people who meet certain medical criteria. So how does this translate into actual weight loss? Three things happen together. Food stays in your stomach longer, extending fullness after meals. The medication acts on appetite centers in the brain, which appears to quiet hunger signals and cravings. And improved insulin sensitivity shifts the body's overall metabolic environment in a way that supports weight loss, especially in people who started out with insulin resistance. Now, the number people actually want to know. In major clinical trials, participants on the higher dose versions of these medications lost, on average, somewhere in the range of 15 to 20% of their starting body weight over roughly a year to 18 months, compared to a much smaller amount in people taking a placebo. Picture it this way. Someone starting around 200 pounds might, on average, be looking at a change measured in tens of pounds over more than a year, not weeks. That's a real clinically significant number, and it's part of why there's been so much attention on this category of drugs. But here's the part that gets lost in the headlines. That's an average. Individual results varied enormously in the same studies. Some people lost far more, some far less, depending on dosage, how long they stayed on treatment, their starting weight, their diet and activity levels, and their own biology. If someone tells you exactly what you'll lose before you've even talked to a doctor, that's a red flag, not a promise. Let's talk safety, because this is genuinely the section your doctor will spend the most time on, and for good reason. Start with the common stuff. Nausea, vomiting, diarrhea, constipation, and general stomach discomfort are frequently reported, especially when starting the medication or increasing the dose. Most people describe these as tolerable and say they ease over time as the body adjusts. Some people don't get that relief and need dose adjustments or have to stop altogether. Then there's the less common but more serious side of the list. Pancreatitis, inflammation of the pancreas, gallbladder issues including gallstones. In rare cases, kidney problems, usually tied to dehydration from significant vomiting or diarrhea, and a specific warning tied to a risk of thyroid tumors based on animal studies, which is why these drugs generally aren't recommended for anyone with a personal or family history of certain thyroid cancers or a rare condition called multiple endocrine neoplasia type 2. That's exactly the kind of family history a doctor needs on record before prescribing anything. And it's exactly why sourcing these medications without real medical oversight isn't just risky in a vague sense, it's risky in this very specific documented sense. One more safety point that doesn't get enough attention: muscle loss. Research has shown that a real portion of the weight lost on these medications comes from lean muscle, not just fat. This is why doctors and dietitians increasingly push protein intake and resistance training alongside treatment, because losing weight and losing healthy weight are not automatically the same thing, and the scale alone won't tell you the difference. Now, here's a question almost everyone asks eventually: what happens when you stop? Based on current research and clinical experience, weight regain is common after stopping, largely because the appetite signals the medication was suppressing come back once it's out of your system. This has pushed many doctors to describe these medications less like a short course of antibiotics and more like blood pressure or cholesterol medication, something managed long-term for a chronic condition, not a temporary fix. And that's a completely different financial and lifestyle commitment than most people picture when they first hear about these drugs. And it's worth having that expectation set clearly before you ever start. And here's something that surprises a lot of people when they first hear it, because demand for these drugs exploded so quickly for weight loss. Actual shortages hit pharmacies in multiple countries, to the point where some people with type 2 diabetes, the exact patients these medications were originally built for, struggled to fill their own prescriptions. The drug designed to manage their blood sugar became harder to access because of demand from people using it for a completely different purpose. That's not a reason to feel guilty for being curious about these medications, but it is a reminder that this entire category exists inside a much bigger, messier supply and access story than most people realize. Which brings us to the other side of that access problem: cost. These medications are expensive in a lot of places, and insurance coverage swings wildly depending on your diagnosis, your country, and your specific plan. That gap has pushed some people toward unregulated sources, compounded versions from pharmacies without proper oversight, or products bought with no prescription at all. Doctors and regulators have raised real alarms here. These products may carry inaccurate dosages, contamination, or may not even be the actual medication. This is the single clearest safety message in this whole topic. Getting these drugs outside a real medical relationship isn't a shortcut. It's a completely different risk category than the side effects we just covered. So who are these medications actually built for? Generally, people with type 2 diabetes or people considering weight management who meet specific criteria, typically a certain body mass index threshold, often alongside a weight-related condition like high blood pressure, high cholesterol, or sleep apnea. That's a decision built on full medical history, current health conditions, other medications, and personal risk factors, reviewed by an actual doctor with actual lab work, not a quiz on an app. One more thing worth saying directly, since there's a lot of noise around this topic online. These drugs aren't a replacement for nutrition, movement, or the deeper reasons someone might struggle with food and weight. Doctors generally frame them as one tool among several, working best alongside real lifestyle support, not instead of it. But it's just as inaccurate to frame difficulty losing weight as pure willpower. Body weight regulation is a genuinely complex mix of genetics, hormones, environment, and biology. And that complexity is exactly why a medication targeting those hormonal pathways directly has been such a significant shift for people who tried diet and exercise alone for years without the results they were told they'd get. If you're considering this path, here's what to actually walk into that appointment with. Ask about the realistic range of results for someone in your specific situation, not the headline number. Ask about the full side effect list, not just the common ones. Ask how you'll protect muscle mass and nutrition during treatment. Ask what the long-term plan and cost look like. And ask what happens if you eventually stop. So here's the real takeaway. GLP-1 receptor agonists aren't a miracle, and they're not something to fear outright either. They're a hormone your body already makes, turned into a serious medical tool, with real benefits, real risks, and a price tag and supply chain still catching up to the demand. That combination deserves a real conversation with a doctor who knows your actual health history, not a version of someone else's story from social media. Thank you for watching. If this helped clear things up, subscribe for more breakdowns like this one, and tell us in the comments what you'd want covered next.